All right, let's discuss facet weight-bearing considerations. It's a tripod, so we have the intervertebral joint in the front and the facets in the back. Of course, the intervertebral joint is the disc-body relationship. For compressive loading, if you were to stand erect with both hands to your sides and then someone were to put a 25-pound dumbbell in each hand, the compressive load would be distributed 80% through the anterior column, or vertebral body and discs, and approximately 20% through the posterior column, or the facets. It's an average. The lower lumbar facets typically bear more weight and more compressive loading than the upper lumbar facets. There is a variance in research concerning the amount of weight that is transmitted through the facets during loading. There's just 4 of many articles and research projects to try and determine that. A general consensus would be 20% compressive loading through the facets, 80% through the vertebral bodies and discs. When you add degenerative disc disease, you increase weight bearing to the facets anywhere from 47 to 70%. Of course, the greater the level of degenerative disc disease, the thinner the disc becomes, the more posterior the inclination of the disc sits at, the greater the weight bearing and compressive loading on the facets. When that happens, you're going to get impingement of the facet tips, and you're going to get osteoarthritic changes into the facet joints themselves. It starts a cascade of degenerative changes, beginning generally with the disc in the lumbar spine. Okay, what are the effects on facet loading during straight axial compression, flexion with rotation, and extension with rotation? Well, with direct axial compression, when there's no additional loading, so in other words, loading is neutral, just the weight of your body, the balance point, or kind of the pivotal point that the compressive load or the weight is balanced around, is in the posterior aspect of the disc. But as soon as you bear a compressive load, that immediately shifts backwards into the facets. If you've ever done any weightlifting where you just bend forward and lift the weight, you may notice that there's a compressive force or feeling, or maybe even a mild dull ache in the lower back, and that would be the loading of the facets. All right, if you add extension and rotation to this, you can actually increase loading to the facets anywhere from 10 to 30%. If you bend forward with that compressive load and rotate, then the compressive forces are negligible, because you've now shifted, because of the flexion, you've shifted the compressive load purely into the vertebral body and disc and pretty much out of the facets. So during axial loading or compressive loading, extension and rotation are likely to be the movements that are related to facet injury. All right, let's talk about the shear load capacity of the facets. And shear is translation, and of course the shear load capacity would be the ability of those facets to inhibit translation. And it varies from the upper lumbar spine to the lower lumbar spine. So if we look at this, the surface area of the facet, so in other words, how little are they, or how bulky are they? As we go from L1 to S1, uh, their their general mass increases. So as we start in the upper lumbar spine, their general mass is small. When we go down the lumbar spine, their mass becomes greater. And the facet angle varies with a more coronal orientation in the lower lumbar spine, which gives great shear resistance, right? And a good example of that would be there. That is the movement of translation of the lower lumbar vertebrae that would create shear, or that vertebrae wanting to slide forward. If you'll notice, in the upper lumbars, most of the facets are sagittal. This doesn't afford good shear resistance, but it does afford good torsion resistance. In the lower lumbars, the facets are mostly coronal. This affords great shear resistance, but the trade-off of having minimal shear is that they do not resist torsion very well, and so you're more prone to a torsion-based injury in the lower lumbar spine if there are coronal facets than you would be if there are sagittal facets. So each set of facets has its advantages and disadvantages. And again, to reiterate, the anterior column in terms of shear load resists about 22% of the P to A and A to P shearing of the vertebral body, one upon the other. The posterior column resists about 78%. I guess we can just round that off. It's about an 80-20 split. The posterior column is the major player in resistance of shear loads within the lumbar spine. All right, concerning facet loading, unequal facet loading, which does occur, leads to unequal facet degeneration. Let's take a look at the mechanism behind that. Typically, it starts with an asymmetric disc injury at one level, and most disc injuries are asymmetric. They're usually right posterolateral or left posterolateral. This is an example of a patient of mine, and you can see what's happened to these facets here, L4, L5 on the right. Tremendous osteophytic, hypertrophic changes in that facet. And then you can take a look at the disc at that same level, and you'll notice there are advanced degenerative disc changes. And if you remember, when that happens, you get an increase in weight bearing, 47 to 70% to the facets. And in this particular case, it has focused most of its damage to the right side. So we start with an asymmetric disc injury that disturbs the kinematics of that level, and then you get asymmetric facet movement, asymmetric facet loading, unequal sharing of weight bearing or compressive loads, and then high load on one facet is going to cause that ipsilateral facet arthrosis. So it's kind of again a cascade of effects that typically starts with a disc injury and ends in both degenerative disc disease and facet arthrosis and spondylosis. And sometimes it occurs equally bilaterally, sometimes it occurs more unilaterally, like we see in this example. All right, this is the degenerative cascade model or triad of Dr. Kirkcaldy Willis, who is an orthopedic researcher, and he states that there's three joints, right? We know it's a triad of joints, the intervertebral joint and the two facets, and that there's three predictable chain of events that any functional spinal unit can go through. So at any point in time in anybody's life, I guess we can take a 50-year-old. We'll just say that's half-life, although it's probably beyond that for most people. If we look at any functional spinal unit in the lumbar spine, and of course we can take this throughout the thoracic and cervical spine, The functional spinal unit is either normal, like we see in the picture here, or it is in stage 1, stage 2, or stage 3 of this cascade triad. And stage 1 is dysfunction, stage 2 is instability, and stage 3 is stability or stabilization. Stage 1 or dysfunction, probably many of you out there have functional spinal units like this within your lumbar and cervical spine. It could be traumatic in origin or cumulative, but it leads to issues in the facets, such as inflammation or damage to the cartilage, as well as issues in the disc, such as annular tears. It's not necessarily painful, although it could be. It's not readily apparent on X-ray, although you will see evidence of it as it progresses further into the next stage, which would be instability. So at this point, we have significantly more damage to the cartilage. We've got laxity of the facet capsules. And when the facet capsules become lax, you get excessive movement. We also have increased disc thinning. And of course, when you get increased disc thinning, then the whole functional spinal unit becomes hypermobile or unstable. You get tears within the annulus, both the circumferential and the radial variety, and you get a lot of translation with different movements. So when a patient flexes forward, that vertebra slides forward. When they extend backwards, that vertebrae slides backwards. Same thing with lateral flexion and rotation. You just get a lot of slippage. This is the patient, and you'll see a lot of these, who with literally the least amount of provocation goes from either asymptomatic or mildly symptomatic into a severe episode, right? And you'll have these folks, and unfortunately, they don't take care of themselves. They're typically overweight and under-exercised, and they will do something simple like get out of the car, and boom, their back is out. Okay, and so you get the phone call, and they schedule the appointment, and they come in, and they're ambulating in a guarded fashion, and they'll just tell you exactly what happened. Doc, I was fine. I mean, I might have had a little ache or discomfort. I got out of the car, and all of a sudden, boom, and that's because the segment is unstable, and they likely now have some type of meniscoid entrapment and a locked facet. All right, and the final stage is stabilization. These actually become pretty quiet, and this would be in the aged spine. It's going to be a 60, 70, 80-year-old spine where you have tremendous loss of joint surfaces, of cartilage. You have bony hypertrophy and spurring. Joint space is very thin. The nucleus is probably dried out and completely deteriorated. Irregularities in the end plates, and possible damage or scarring to the nerve roots. Generally speaking, though, when they get to this point, not in every case, but generally speaking, these become quiet. And actually, the way Dr. Cox puts it is the party moves to the next story above, or to the next floor above. And the reason why these quiet down is because you have greatly diminished movement now in the facets and in the vertebral body, and the less movement, the less problematic a functional spinal unit becomes. All right, so once again, in any given spine, like I said, if we take a 50-year-old, they're going to have a broader array of all three stages. Their functional spinal units are either going to be normal, in a state of dysfunction, in a state of instability, or they're stabilized. Usually have a wide array of all of those in the aged individual. All right, a few radiographic concepts concerning Facet syndromes. According to Dr. Cox, based on his studies, if you remember from the initial study in the beginning of this lecture, they rated chronic low back pain coming from the facets at about 15% of chronic low back pain sufferers. Dr. Cox, in his research, feels like it's about 26%. And as you see right over here, just other studies, it just depends. The exact degree of low back pain, really caused by any tissue in the lower back, pretty much unknown. There's a few useful lines of mensuration that we'd like to expose you to, and you may be familiar with these. We're going to go through them quickly, but the first one is McNabb's, and McNabb's basically determines whether or not you have a hyperextension malposition of a vertebrae, which really leads to or potentially is a Facet syndrome. How do we do it? You construct a line on the inferior end plate of the vertebrae above the two that you're examining. In this case, it's the sacrum and the fifth lumbar. You construct a line on the superior end plate of the vertebrae below. Normal cross point should be posterior to the facets, maybe at or posterior to the facets. It is considered that they have a hyperextension subluxation or malposition, or a Facet syndrome if you want to use the term, if the lines cross at the facets or particularly anterior to them. The closer they cross to the facets, or if they're actually way forward, the greater the level of extension malposition and the greater the potential of a Facet syndrome, as well as posterior disc space narrowing, IVF narrowing, and just hyperextension of the vertebral body and compressive load on the facets. Also, the tip of the superior facet, which is seen right here in that arrow, that's what that arrow is pointing to, that superior facet should not lie above the inferior end plate line, right? It should not lie above this line over here. If you see that, that definitely indicates facet imbrication, or kind of an overlapping or a compressive loading of the facet. So that's McNabb's. Here's a few examples of it. To the left is normal. You can see that they really don't cross, but if they did, it would be posterior to the facets. And so that would indicate really a normal 80-20 split over here, where the vertebral body was getting 80% of the compressive loading and the facets were getting 20%. In this example over here, you can see that the lines intersect right at the Z joints, and that vertebrae is in an extension malposition, and that of course is going to change the weight-bearing load greater onto the facets, less onto the vertebral bodies and discs, creating potential facet or zygapophyseal joint pain. Van Acker-Beekens, similar line drawing in a sense. This is used to discern or ascertain stability of a functional spinal unit. Right? We mentioned in Kirkcaldy-Willis's triad of the three different phases that a functional spinal unit can be in, which would be normal, instability, or stability. This would allow you to determine if a functional spinal unit was in that stage of stability, indicating damage to the PLL and the annular fibers as they attach to the vertebral end plates. It can be used as a prognosticator in terms of how well the patient may respond, and it does assist you as a doctor in predicting general future difficulty based on where the what the lines express in terms of instability. All right, how do you draw these? You construct, again, a line on the inferior end plate of the vertebrae above, a line on the superior end plate of the vertebrae below. All right, the cross point is labeled A. You now measure from cross point A to the posterior inferior margin of the vertebral body, which we'll list as B, or that would be AB. And then you measure from cross point A to the posterior inferior margin of the inferior vertebral body. In this case, it's the sacrum. That would be AC. All right, and once you've made those measurements, here's the formula. A difference between those two measurements of 3 millimeters or greater indicates that you now have an unstable functional spinal unit at that level. All right, so as we see up here, 3 millimeters or greater difference indicates that the PLL and the annular fibers have been damaged, resulting in slippage of the superior vertebral body and instability of the functional spinal unit. Fairly easy to do, and this would, again, also be a prognosticator as to the therapeutic response of your treatment, and it may indicate that the patient needs exercise, possibly bracing, and ongoing maintenance or supportive care in your office. And here's a few examples to the left. Right, if we measure from A to B, which is right there, that's 11 millimeters. If we measure from A to C, which is right there, that's 12 millimeters. So 1 millimeter difference. So that's a stable functional spinal unit. But over here, A to B is 11, A to C is 16. Of course, that's greater than a 3 millimeter difference. That is an unstable functional spinal unit. All right, and then the sacral base angle or the slope. This really just helps to determine if there is an appropriate compressive loading into the discs and facets, or if one is getting too much or the other is getting too much. The ideal sacral base angle is 41 degrees, and this was determined by Helms and Keats in their research. At that degree of angulation, 80% of weight bearing is carried by the vertebral bodies and 20% by the posterior facets. According to this research, although only 20% of weight is carried on the facets, the pressure per square inch on those facets is 10 times greater than the pressure on the knee of an upright person. So basically, an increase in the sacral base angle shifts weight onto the posterior elements or the facets. A decrease in the sacral base angle shifts weight onto the anterior column or to the vertebral bodies. And here's a good example of normal. Of course, that's the 41-degree angle that we're talking about, and here it is again. And with this configuration, we have 80% weight bearing into the anterior column, 20% into the posterior column. Here's a 30-degree, right? So it's a decreased sacral base angle. That's going to increase compressive loading into the vertebral bodies and to the discs. And here's a significant increase over here, way right, 60 degrees. That would be a very hyperlordotic lumbar spine. And you're going to get severe compression on the facets and less compressive forces coming down into the vertebral bodies and the discs. All right, this is just something I kind of accumulated through years of studying all this stuff, and these are the 18 hazardous structural factors of the lumbosacral region, or the joint between the fifth lumbar vertebrae and the sacrum, which many authors, not all, but many consider the single most common site of problems in the vertebral column. All right, so number one, it bears more weight than any other vertebra. The center of gravity goes right through the joint. It's a transition point between the mobile spine and the relatively immobile pelvis, right? L5 is the last freely movable vertebrae, and then the pelvis is a pretty stable bony structure. We have a tremendous degree of flexion and extension at that level. You have the largest nerve root, or nerve root complex. We can say the neurovascular bundle. We have the smallest disc in the lumbar spine, the smallest IVF, the largest DRG, the most intraspinal or centrally oriented DRG, the deepest lateral recesses. It's a common area for arthritic degenerative changes. It's a common area for pars defects, resulting in spondylolysis and listhesis. It's an area where the PLL is thinnest. It's a shift point of weight from the anterior column to the posterior column. It's a transition point from a large vertebral body to a smaller vertebral body. It's a common area for facet tropism. It's a common area for a trefoil-shaped spinal canal, which is the narrowest of all spinal canals. And it's a common area for genetic anomalies, such as lumbarization, sacralization, and transitional lumbosacral segments. So it's an area destined for trouble. All right, lumbar facet pain patterns have never been charted or mapped. Nobody knows why. The facets in the cervical spine have been charted and mapped. But the lumbar facets basically send widespread referral sensations into the lower extremities. They're diffuse. Remember, they're non-radicular in character. They're not sharp, stabbing and lancinating. They're dull and achy. Generally difficult for the patient to localize. Never below the knee, but never say never. They can go below the knee, we know from a research perspective, but in general, during the day-to-day practice, they don't. Typically isolated to the buttocks and thigh, just like you see right over there. That's a common facet patch right there. And there's no sensory or motor deficits. There's no neuros because the nerve root is not involved. So when motor and sensory changes are noted, when there are neuros, you should not suspect a facet. You should suspect a disc lesion. All right, this was an interesting study where the zygapophyseal joints were stimulated experimentally with various forms of noxious stimuli. And here is the findings. And I'm just going to sum it up for you, real quick. This area here is from mild stimulation to the facets. That's where the pain referred. This area here, these kind of lines here, you can see them even going up into that area. That's from moderate stimulation of the facets. And then the darker area is from major stimulation of the facets. So it has been noted that the distance of the referral is proportional to the intensity of the stimulation. The greater the stimulation, the further the referred pain spreads down the length of the lower extremity. All right, so these are some clinical features, that may be present with lumbar facet pain. Tenderness to palpation of the facet joint, T2P, it's a little abbreviation for tenderness to palpation. Pain relieved by recumbency, which gets the weight off the facet. non-radicular, right, non-dermatogenous pain pattern into the lower extremity. Of course, extension movement is going to worsen it. And as we mentioned previously in one research study, extension and rotation is going to load the facets and increase it. Pain is worse when they arise from a forward flexed posture, because when they're forward flexed, the compressive loading is off the facets. When they arise from that posture, the facets get loaded. Radiographic signs of facet issues, absence of neuros, and no positive nerve root tension signs. There wouldn't be any, because those are designed for determining if there's a space occupying lesion in the path of a lower lumbar nerve root. Alrighty. All right, a few clinical tidbits in discerning radicular pain from referred pain. Pain in the absence of neurologics is likely referred. Pain in the presence of neurologics is likely radicular. All right, however, take into mind that there may be no neurologic signs in the early stages of a radicular lesion, because the compressive forces have yet to create neural edema and dysfunction of the nerve. So some people come to you right away when they know something's wrong, and these type of lesions or injuries where a disc is effacing a nerve root could take upwards of 72 hours till they begin to feel symptoms from it. All right, referred pain versus radicular pain. All right, let's say a patient comes in with a low back disorder and leg pain. If it's referred or somatic referred, you may be more familiar with that term now, typically the back pain is greater than the leg pain. If it's radicular, which means a disc is involved, typically the leg pain is greater than the back pain. That's a great little tidbit when you're sitting and doing a consult with a patient and they tell you, I've got back pain and it's going into my right leg. Ask them, which is worse? Is it the back or the leg pain? Oh, doc, it's the leg pain. I just want to cut it off. That's likely radicular pain. If they say the back is worse, then it's likely referred pain going into the leg. All right, and then response time. With referred pain, typically it's mechanical in origin. The patient response to treatment is usually pretty quick. With radicular pain, that's usually discal in origin. The patient response to treatment is typically much, much longer. And you need to tell them that when you sense through all of your clinical findings that this is a disc issue, let them know this is not an overnight case, and clearly explain to them the nature of what's going on and why it's going to take 60 to 90 days to resolve their condition. All right, we mentioned that the cervical facets have been mapped, and here they are. That's a pretty common chart. Maybe you've seen it before, maybe you've not, have not. But here's an interesting study that was published in 1990. 10 symptomatic patients record a distribution of their neck pain on a diagram. The diagrams were compared to this chart right here. And then facet nerve blocks were given at the predicted level. Right? This is a research study. 9 out of 10 received complete relief. So the cervical facet referral pain patterns have been mapped and charted and are accurate, or kind of in stone. They have not been able to do the lumbars. Nobody knows why. There's just a variance across the board where they cannot come up with a conclusive map for each facet level. All right, facet syndrome or facet pain treatment options. Of course, if you're medically oriented facet injections. They're short-lived and mainly used for diagnosis. Of course, if the patient gets relief, then they know that the pain is being mediated by the facets. Medial branch blocks do the same thing. They basically block the dorsal medial branch of the dorsal ramus. Again, it's more diagnostic to determine if the pain is coming from the posterior column or the anterior column. All right, this is their answer, medically speaking. If they feel the facet is the source of the chronic or acute low back pain, they will often recommend radiofrequency facet denervation. And that's where they go in and they block the three medial branches to any one particular facet. They blow it out with radiofrequency waves. After it's done, it feels like a sunburn on your back, and after about 6 to 8 weeks, that sensation goes away. And if the pain was truly or solely coming from the facets, they will be pain-free for approximately a year. And then those nerves will regenerate, and it has to be done over again, of course, if the patient wants. All right, the gold standard, that's why it's in gold, is the chiropractic adjustment. 39 years of helping people with facet issues. I've never seen anything work as well. There should be a law before any of this invasive procedure is performed or even recommended that chronic low back, acute low back pain patients need to see a chiropractor for 90 days, right? We're non-invasive. We don't put anything in, we don't take anything out. We just fix the alignment and mechanical aberrations that we find through our chiropractic analysis. And then, of course, you have PT. The PTs do fine with some of these cases, and I don't think they come anywhere near in their success to treating these as we do with our chiropractic methodologies. All right, so that's a lumbar facet joint injection. That's one way that they'll do it to see if the facet is causing the pain. They'll actually puncture the capsule and just fill the capsule with an anesthetizing agent and see what the patient's response to that is. Of course, if they get a lot of relief, then they're going to want to go in and do, some of these procedures, this radiofrequency procedure that we just mentioned. Medial branch blocks, right? They're not going into the capsule. They're just basically numbing the medial branch of the dorsal ramus at all three levels to the facet. And again, it has basically diagnostic value to determine whether or not they want to do radiofrequency nerve ablation and just totally knock the nerve out or the nerves out. That's the denervation. That's what it looks like, and it's a radiofrequency probe, and they basically just go in there and bombard the nerve with those radiofrequency waves, and it pretty much just damages the nerve and knocks it out, but not permanently. It's temporary. And then, of course, there's the gold standard. There's a good old BJ doing a HIO, hole-in-one cervical toggle, and then this is just standard double pice form manipulation of the lower lumbars. All right, patient management tip, very important. Patients need to understand the importance of keeping their appointments, and that is done through a team effort of you and your staff. The patient needs to be informed or educated and understand that each adjustment builds on the previous one, and when you skip or miss your appointments, you delay healing, right? They don't want to delay healing. And you prolong treatment. They don't want to prolong treatment. That means they've got to pay more and be in your office more. So when they miss an appointment, let them know that you know. And the staff needs to let them know as well. So confront them lovingly. Let's say it's Wednesday and Sally should have been on, or Mrs. Jones, what we have here. Mrs. Jones should have been here Monday. Confront her lovingly. Mrs. Jones, I noticed you missed Monday's appointment. And then shut up. Right? They'll stumble and fumble. Doc, is it really necessary for me to be here 3 times a week? Or every other day, whatever your recommendations were. That's the confrontation point. That if you don't manage it right there and then, the patient's just going to come in on their own schedule. Mrs. Jones, I would have never recommended that we see you daily or 3 times a week if I didn't think in your case that it was absolutely necessary. The schedule of care that I outlined for you is actually essential in order to achieve the results that I know we both desire. My recommendations, Mrs. Jones, are based on years of experience with cases just like yours, and I know this is what works. Mrs. Jones, if you were my mom or my sister, these are the exact recommendations I would be making. If you say that or something along those lines, the chances of them ever missing another appointment are very slim, unless you just have a totally non-compliant patient, in which case you don't even want them in the office anyway. They usually disappear on their own accord.